to do the opportunity cost that they're going to lose to get it. And that's the reason why BARDA, with the Biomedical Advanced Research and Development Authority, which has money to invest in the pharmaceutical industry to take a product that's generally developed by researchers. Yes, it is going to be a challenge to be able to get a major company to do that. And I think for the reason that Ron alluded to, because when we were doing this with Ebola, it was a major vaccine company that got burned, who's now pulling out of that. So that is a challenge, yes.
Yeah, in fact, that there is now a licensed Ebola vaccine, but that took years and years and years. And the company Merck that brought it to license has no hope of recouping the costs that it put into developing that vaccine. And a couple of years ago, I actually wrote a piece. I talked to all of the major producers, and they'd all effectively been burned at least one or two times. You know, Sanofi had tried to make a Zika vaccine, and that didn't pan out. They'd also earlier tried to make a chikungunya vaccine. I think it was Sanofi, was it not?
Right.
Time and again, the industry is asked to step up and produce emergency vaccines in circumstances like this, and then the emergency passes and people don't think they want the vaccine. It even happened during the 2009 flu pandemic, which turned out to be milder than people had feared at the start. And then when the vaccine was ready, people didn't want it. So the vaccine manufacturers have been to this dance before. They go away, you know, having lost money, having given up time that they could have put on other projects. It's a very difficult situation for them. Consequently, if you look at who has actually announced that they're going to do anything at this point, only J&J of the major vaccine manufacturers has said that they're going to try to make a coronavirus vaccine. GSK has said that they'll let somebody else use their adjuvant, which is a compound that sort of boosts the impact of vaccine, which means you can stretch it out and vaccinate more people. But the other major manufacturers have been silent up until now. Do you know anything? Are they going to get in?
No, and that's the thing that it's the issue that we've dealt with, Helen is very well aware of it, is the opportunity costs of these organizations. Because if they're going to shift over and make a vaccine for an outbreak that may not necessarily occur, they're not making a vaccine for the things that they're making their money on. And that is very, very difficult to get someone to do. We've tried, we being the federal government, to make investments. You know, we had long conversations about that. I'll just very briefly say it. Is, in other words, if you're going to get a factory that is not going to ruin anybody's opportunity, so it's doing nothing but staying warm, ready for you to come in and make your 400 million doses of whatever it is you want to make. It doesn't work that way. It doesn't, because the companies that have the skill to be able to do it are not going to just sit around and have a warm facility ready to go for when you need it. When you need it, they're going to have to stop making polio vaccine, measles vaccine, hepatitis vaccine to put your particular product in. You're right. It's very difficult and very frustrating.
So I just raise that because I think we need to be very careful about how many promises people get about how soon vaccine will be ready.
I never promise. I never promised you a rose garden, Helen.
Okay, great.
I'm telling you the timeline. I'm not promising anything. Right?
Okay, so Dr. Messonnier, given that we've established that it's going to be a while to vaccine, and and this virus may end up circulating here. I mean, what do you think, knowing what you know about it so far, what kind of measures do you think CDC would be looking at? I mean, school closures, there don't seem to be a lot of sick kids with that, and this infection, and school closures have huge implications on families. I mean, what would you look at?
Yeah, this is really difficult. From a CDC perspective, a lot of the work that we're doing on this coronavirus rests on the foundation of the planning we've done for influenza. Mm-hmm. So because of the threat of pandemic influenza, we've thought a lot about what we would do in exactly this situation, when we were faced with a new respiratory pathogen and we didn't yet have a vaccine. And the kind of things that we're talking about is social distancing that is trying to keep people from transmitting to one another. The school children thing is an interesting question. There are multiple hypotheses for why there haven't been many cases in children, but one hypothesis is actually that there has been, but it's mild illness. And it would be unusual for kids in this kind of situation not to be getting sick. So it's possible that we will find that there is illness in children. Children sometimes are the ones who actually seed their household. And so there might be a situation where we would want folks to think about keeping kids home from school. What's different now than it was 10 years ago when we first really started thinking about this is the availability of teleworking, teleschooling, and telemedicine as ways to keep people from congregating, including in their physician's office. So we're looking at all of those things to come up with how we might operationalize social distancing. The other kind of things that you end up asking are not to have mass gatherings, not to have lots of opportunities for groups of people like this to be passing germs back and forth. And it is hard to operationalize that at a large enough scale. But the truth is, we know that if we do those things, it can work, and it also can buy us more time. When we use mathematical modeling to look at the trajectory of an epidemic, putting in place those kind of social distancing tools keeps it from coming quickly, buys you more time to the eventuality of hopefully eventually a vaccine, and frequently lowers the peak of disease, because what we also don't want is everyone getting sick at once. It'll overcome the healthcare system. So it's not just about preventing it, it's about trying to scale it and time it so that the healthcare industry can manage the patients that we might see.
Best guess what we're looking at here? I mean, one of the problems with this is that, as we heard earlier, there isn't a really good sense of how much mild disease there is. So when people are talking about 2% of patients seem to be dying, that's obviously going to turn out to be wrong. I think it's likely that it's a smaller fraction.
Right.
2% would be a disaster. What do you think we're looking at in terms of case fatality? Would you even venture a guess?
Well, yes and no. I mean, because you don't want something to come out as this is a prediction or whatever. But if you look at the relative mortalities that we have, so right now the mortality, counting just the people who are accessing the healthcare system, is a little bit more than 2%. It was hanging around 2%. It's like 2.2 now, 2.1. SARS was 9 to 10%, but that did not transmit very well. But the thing you really want to compare it to, because we have a lot of experiencing with it, is seasonal influenza. So seasonal influenza is about 0.1% or so. Now, if you look at pandemic influenza, look at 57 and 68, it went up to about 1 or so, a little bit less than 1, a little bit more than 1. And when you talk about the catastrophe of 1918, that was close to 2. So right now, if we're at 2, I believe, though I don't know for sure, Helen, that it's going to be multifold less than that. I think it likely is going to be down to 1 or below 1. I think. I don't know. But I don't know. I think it's going to do that, because if it's half of 2, that's 1. I think, and I think that, and again, Nancy's going like this to me, be careful, you're gonna have to eat your words. I'm saying, I don't know, but I'm just saying, what is my imagining it would be? If there are twice as many people who are sick, who are infected, either asymptomatically or minimally symptomatic, then you bring it down to 1. If you could bring it down to 1 or below, from a dynamic standpoint, it's very different from influenza, but it would be acting like a really bad influenza season if it were that. A really bad one, not a mild one, but a really bad influenza. That's the possibility. Now, having said that, it could be multiple other versions of it. Right. So that's the reason why it's, you could surmise what it's going to be, but I don't know what it's going to be. And that's the thing that drives all of us, is that we don't know because we haven't had prior experience with this particular infection.
I just will add one thing. I'm not going to predict.
I'm not predicting. You give me options. You know?
But well, another thing that really you need to factor into your thinking is how quickly this rose to high rates of disease, high number of cases in Wuhan. And you can imagine that the healthcare sector in Wuhan was likely rapidly overwhelmed by the number of cases. It probably impacted people's willingness to seek medical care. It may have impacted the ability of the healthcare sector to provide optimal care for everybody. And so we also don't know how much of those deaths reflect the societal disruption that's happened to the unfortunate citizens of Wuhan, and whether, again, by giving ourselves more time, being able to slow the pace of it, whether it will help us in the eventuality that we need to care for these patients.
I think if we have questions from the audience, this would probably be a great time to start. We have one down here.
Yeah, wait, we've got microphones
Let me thank the panel for a really interesting conversation. I'd like to talk a little bit about the politics, Dr. Fauci and Ron. Is there an interagency process? I'm sure there was during the Obama administration, but is there one now where you have some line of communication between NIH, CDC, the Defense Department, Homeland Security? We have sailors who wanted to get into Hong Kong, couldn't, but they might have, and might have become infected and come back. So all of these agencies would be very much involved from a national security point of view. So first issue, is there a really good interagency process? Second thing to you, Ron, in particular, have we a public affairs strategy, namely that we have a warm policy whereby we know when something like this happens, here are some of the parameters we have to operate within. And then to have that, and you can adjust it up or down, but also does it deal with social media? Because social media is where most of the extreme conspiracy and other types of things take place. So within the interagency process, is there a way to plan on having a real strategy that can be implemented to counter that and to spread good information, whatever you have, from a trusted source? Now, when you get into trust, that's a whole different issue in terms of the administration, because the president has said it's over. It's reached its apex at this point. So I think there has to be something within the government that communicates to each other, but also has a real public information policy.
Okay, Dr. Fauci first.
Yeah, so what we have is in the Department of Health and Human Services, the effort is clearly led by Secretary Azar, which involves CDC, NIH, FDA, ASPR, BARDA, et cetera. But we also frequency, and when I say frequently, I mean like really frequently, every day at least, sometimes twice a day, have a meeting that is generally chaired by the National Security Council. And we do that, and that's the interagency. It's a PCC, which you're very familiar with. You've been in many. A PCC that we have at least once a day and sometimes twice a day. We have one at a lower level. Every once in a while, we get the deputies there, and it involves the interagency. So right now, we also have put together the coronavirus task force that includes individuals from the different agencies. So there's an extraordinary amount of communication, literally on a daily basis,
In terms of the social media thing, you guys are doing something at least with Twitter, because I know that if you search coronavirus on Twitter, right at the top of the page, the first thing that shows is a message about looking for good information sources and check the CDC.
Yeah, so my day job is working on vaccines. And so clearly with issues around the United States of misinformation about vaccination spread through social media, when this outbreak first evolved, it was clearly important to us to make sure that we do what we could to at least make sure that technically correct information is highlighted in social media. And because of the background work that we've done, Pinterest, Facebook, and Twitter, at least those three, all have, if you search, the top line sites and the top line information is well-curated information from CDC. I think that's a success. Unfortunately, if you read farther on, you can find misinformation, but at least they're leading with stuff that is scientifically credible.
Ron, did you have something?
So just quickly, I'd say, number one, I've said this publicly before, I've written about this. I think it's a mistake that President Trump has not named someone at the White House to coordinate the response on this on a full-time basis. After the Ebola response in 2015, we recommended to President Obama that we set up a permanent unit in the National Security Council, a global health security unit, led by a director of pandemic preparedness. President Obama accepted that recommendation. That continued through the first year and a half of the Trump administration. When John Bolton took over the NSC, he disbanded the unit, sent its head back over to USAID. I think that's missing. Why? Not because Secretary Azar isn't fantastic. He is. Not because there aren't great people working on this, a lot of interagency. There is. But in the end, if this is going to be a whole of government response, it's got to really be run out of the White House. And then there's also a lot of international points of contact, and the people around the world need to know who they're dealing with. And I think that's a weakness. I think on this social media thing, I think what Nancy and her team at CDC have done to try to cope with social media is much better off than we were a couple years ago. But this is a place where public health is just behind, right? It is not a coincidence that information that spreads quickly on social media is called going viral, okay? This is one of the great sources of risk of our time. The ability of misinformation to spread quickly and without the ability of experts to really control it and press it down. We saw a little bit of this during Ebola in 2014. Social media is much bigger now 5 years later. And I think this is just a huge challenge for the public health community.
There's a lady right there.
Excuse me, one second. We've got a lot of people want to ask a lot of questions. I'm going to ask people
Very short.
to the point so we can try and get as many.
Sure, and one, please. One question each, please.
Regarding this international response coordination needed and so on, I'm mystified, and could you comment on China's refusing WHO, US, whatever assistance? Thank you.
WHO is in China now.
Yeah.
They've sent a mission.
Right. WHO has sent an advance team mission there with the thought of having more people. We have made it very, very clear that we would like very much to get a team of our own people there, both to assist the Chinese as well as to have our own eyes and boots on the ground to see what's going on. At this point, as of last night, we have not yet gotten any notification that our people will be able to go there. Of note, the CDC has a permanent office there. The question is they're not yet allowed to go in and essentially be embedded in the response. Hopefully, we'll see a change in that right now, but right now we don't have people there.
Lady right there.
Thank you, Si Yang from the Voice of America. I have a question about influenza and coronavirus. The reason I'm asking because the spokeswoman from Chinese foreign minister wants to comment on the U.S. travel ban. She was saying China, the United States, the influenza in the United States caused more death than coronavirus. So as a result, my friends from China sort of calling me, say, hey, in the outbreak of influenza in the United States. So my question, can we compare this together? I mean, the coronavirus and influenza. And I'm just wondering, what's your expert's point of view here? Thank you.
I think there's two ways to compare that, right? So one is, if you look practically speaking, we're in the middle of the flu season, and the number of cases of influenza in the United States, which is somewhere around 22 million, clearly far exceeds the number of cases of novel coronavirus, COVID-19 in the US, period. The difference is that we have a countermeasure for flu. If you haven't gotten your flu shot, please go get your flu shot. The flu season isn't over, and we don't have a countermeasure for this coronavirus, and we don't understand enough about it yet to have the same understanding that we have of flu. I would also point out for your friends that in H1N1, the question about quarantine and border control came up. But by the time we knew about H1N1, it was already here.
Yeah.
What was different about this is that because of improved detection, global surveillance, transparency, all the systems that have been built, we knew about this disease before it reached our shores, and we had an opportunity to do something.
Right. Can I just very quickly also, it's the unknown versus the known. I mean, as serious as influenza is, which we take very seriously for the reasons that Nancy just articulated, we know for sure, because we have multiple years of experience, that come March, April, May, that we are going to have the end of the flu season, unless we have a pandemic the way we had in 2009. We don't have that kind of experience with this particular infection. We don't know what its capability is and where it's going. There's a big difference. Even though the numbers favor, my goodness, worry about flu, don't worry about this. The known versus the unknown.
Lady right here, please.
Hi, I'm Sabrina Mully with The Hill. How do you, any of you on the panel, think that veiled racism or bias will affect treatment outcomes, especially since there's a lot of misinformation about how this virus came about all over social media? And what do you think health organizations in the US and abroad can do to combat this?
Maybe I'll start.
Yeah.
You know, I heard this story last night that was just really disturbing. I met an Asian gentleman who lives in DC and says that when he gets on the subway, people move away from him. It's startling and frustrating and clearly not the right people to be concerned about the risk associated with. I think we need to try to differentiate for the public the risk which we know of, which is people who have recently traveled to China, especially who are coming out of Hubei province, and not, broadly speaking, every Chinese restaurant in the metro area. And you know, we count on all of you as influencers and as the media to try to get those messages across. So I am worried about the general public. At a healthcare setting, I'm not quite as worried, but I would say that we continue to remind healthcare providers of the importance of asking about a travel history when they treat patients. It should be part of the normal questions that someone asks.
Can I respond to that? I testified before Congress last week about this, and this was one of my key points. And you know, I'll just be very blunt about it. President Trump used his Twitter account in 2014 to spread plenty of hate about Ebola. He should use his Twitter account today to tell people there's no reason to discriminate against people of Chinese origin in this country or Chinese nationals in this country. The virus infects humans, not people based on their national origin and based where they're from. And I think the risk of increasing discrimination in this country against Chinese Americans, against Chinese nationals here is going to escalate as fear fosters this. And so public leaders need to get on top of this and need to tell people that the kind of thing Nancy talked about is the least extreme example. We're going to see kids kicked out of school. We're going to see all kinds of horrible things unfold here in the next couple of months unless we really take a strong stand against it.
There's a lady back there, and then a couple of people up here, please.
Yes, Joan Metrich, a freelance medical reporter. Two quick questions. Could you comment on the Imperial College vaccine that they say is almost ready to go into a mouse model? Secondly, is there any protection if you got your flu shot or if you're among the older over 65 that got the pneumonia booster? Is that protective at all?
Before you answer that, can I hijack that a bit and say, is there a model, an animal model yet? Because I don't know that that's been established.
Right. No, it is pretty clear we almost certainly will be able to get an animal model once we get the isolates to be able to do that. I don't think it's going to be very difficult to get an animal model for a coronavirus. But we don't have one that's standardized yet. But it will be coming soon, I think, Helen. You know, there are a number, and I mentioned that I just gave as a prototype the mRNA vaccine that's being developed by the NIH. But there are a number of organizations, including the Imperial College, is going to do the same thing as I described in detail. They're going to take, you know, a couple of months to get it into a human in a phase 1, but they're going to be faced with the same stepwise problem, not problem, but the stepwise process that we have.
But is there global coordination?
Well, CEPI is involved to a degree.
Yeah, CEPI's involved in supporting certainly the Moderna group, the group that is working with the NIH, when you say global coordination, right now we're going to have global coordination as we always do. We'll have a meeting of the people who are all doing the vaccines, but we're only 6 weeks into this outbreak. So, right.
Lady here with blonde hair, and then the gentleman behind her, please.
Hi, Dr. Susan Blumenthal, former Assistant Surgeon General.
Sorry.
I wanted to ask you about some of the tools that are under development for an effective response. First, is there a rapid diagnostic being developed, like a swab that people can use in doctors' offices? Because right now the diagnostic goes to the state health departments. Two,
Her questions. The lady in the back asked about pneumonia shots and flu shots.
Right, there's no reason to think, so it's great to get your pneumonia shot, you should definitely get your flu shot, but there's no evidence that they would have any impact on this virus. And in fact, again, people who have the worst outcomes are in the older age spectrum and with underlying illnesses. You know, in terms of the diagnostic, clearly a rapid diagnostic that could be used bedside is where we want to get. But I do think that we should appreciate the tremendous accomplishment of, we're talking about a pathogen that wasn't identified until early January, and we already have a PCR out to our state health department partners incredibly rapidly, something 10 years ago we never would have seen. So I think that's an incredible step. What CDC has done is make that PCR available, not just to the states, but making our prototypes available. But we've also taken the virus and isolated it, put it at the NIH's BEI resource so that other academic and industry partners can use it for research as well as for development of new diagnostics. And FDA has also put that pathway together. So certainly bedside diagnostics, that's, you know, hopefully where we'll be. It's not where we are today.
Repurposed
drugs, repurposed drugs. When you get a new pathogen, you either repurpose drugs you already have or you do targeted drug development. We've started targeted drug development, but the repurposing has already started. Remdesivir, which is a nucleotide analog, which, as you might recall, was one of the 4 limbs in the Ebola study that didn't show that it worked very well with Ebola, has some in vitro and model work as well as some empiric use during SARS, which was felt that maybe it had some effect. It has now been initiated in 2 trials in China, which are randomized controlled trials, standard of care versus standard of care plus remdesivir in 500 patients in each trial with advanced disease and with less advanced disease. That's just one. Right now, obviously, people have been talking about anti-HIV drugs such as Kaletra, which is a combination of protease inhibitors. So there are going to be trials, but one is actually already started, the remdesivir.
And the last question, I just want to comment that I guess I want to thank the military for their flexibility and partnership in finding places to house these people. But it would be a mistake to assume that they're in a barracks in the way that we see it in World War II movies, everybody, you know, with cots. These people are housed in a way that allows them to be housed separately. And so that the military bases is actually specifically chosen because it allows us to house people in a way that there's not so much opportunity for transmission. That being said, there's no reason to think that regular disinfection wouldn't work. We have guidance for that on our website. And also now that the virus is available through the NIH resource, some of the first studies that are going to be done are looking at the survivability of the virus on various surfaces as well as some of these questions.
Gentleman there.
Yes, Dr. Michael Duenas, Chief Public Health Officer for the American Optometric Association. I was formerly at CDC. I appreciate you. And thank you for the 3 of you for rapid deployment here for this meeting. But one of the questions I have is that you talk a lot about the death rate and not much about secondary attack rate. And that's very important. We've seen secondary attack rates reported from 1.5 to 3.5, and now yesterday there was a report of 4.1. And that's really how fast it's transmitted through from from person to person. Could you talk a little bit about that and how you're monitoring that?
So I think what you're really talking about is the R naught. So the R naught is a fancy word that is meant to explain how contagious something is. If I have the disease and I transmit to 2 people, my R naught is 2. For comparison, measles, which is among the most contagious of infectious diseases, has an R naught around 14 to 16. Most studies have said the R naught for this is somewhere around the 2 to 4 range. It is a question that everyone wants to know. It is important. I'm not sure that it dramatically changes things. And one of the problems here is that people are rushing to get their data out, which is a good thing. But sometimes it's hard to make sure that all the data has enough peer review to make sure that we know how to interpret it. It's hard to tell in some of the studies if the patients overlap. And it's also hard to know that all of the rigorous science has gone into every one of those investigations. So we're looking at R naught in 2 populations. We're looking at it in China, where there's such an overwhelming number of cases that I suspect is hard to track. And then countries that have had smaller numbers of cases are looking at their clusters. And that's where a lot of this data is coming from. And the question really is, are what we're seeing outside of China completely reflective of what we're seeing inside China? I don't think we know.
Right. Question right here, please.
Hi, thanks. Dan Glickman. You guys are just amazing. You really give us a lot of trust. This pathogen seems to have come from animal transmission to humans. I don't know that for a fact, but that's what I read. They had these live animals in these markets in China, and so many of these viruses seem to have kind of a zoonotic basis to it. They start from animals. The Ebola thing apparently had this as well. Is this accurate? And what are you bringing in researchers from the Department of Agriculture and the people who produce animals? Because if most of these diseases come from animals,
join the fray, Dan.
Yeah,
Right?
shouldn't that? And is that something we should have in terms of our domestic policy as well? This animal to human contact.
Yeah. Well, the answer is, if you look there, this is the 3rd coronavirus that we've dealt with that went from thinking it was just a common cold, because there are 4 coronaviruses that account for anywhere between 10 and 30% of the common colds. But there's a whole bunch of other coronaviruses that infect animals. If you look at SARS, through a lot of investigation, it was felt that it went from a bat to a civet cat to a human. And civet cats that are used as, they're very exotic animals used in feasts that people have, who various feast days, they do them. Then we had the Middle East respiratory syndrome, or MERS, which was felt as showing that it went from a bat to a camel, from a camel to a human. So that even though we don't know a lot, we don't know about this, that it is likely that way back somehow, this was a jump species. It went somehow from a bat to some sort of an animal. That's why they thought the market was where it came, even though that was not the case. People were infected before the market thing came up. The short answer to your question, Dan, it is highly likely that this was a zoonotic that jumped species, because if you look at the phylogenetic tree of bat viruses, they are really quite similar to the coronaviruses. They're in the same category. In fact, if you look, the phylogenetic trees go like that, and this is bat, and this is the coronavirus in human. But your second part of your question is, yes, obviously, we're looking at the interface, and we use people who are experts in following animals over a period of time. We see this with influenza, where you have the proximity of people and pigs and ducks and chickens, and that's how you get the jumping of species. When you have customs that go back for centuries of people who go to wet markets and interact with animals that are exotic animals, you're going to see these kind of things.
Gentleman there, and then the lady there, and then I think we may have to...
Irving Lurch, physics community. Sorry. This morning in the New York Times, there was an op-ed piece by Professor Lung from the World Health Organization. He addressed a number of the issues that the panel has been covering here. He raised a couple that that I would like some clarification about. He talks about SARS, for example, and he said that the initial outbreak led researchers to conclude that the infection rate, the mortality rate rather, was between 1% and 2%, but that when epidemiologists did the statistical modeling, they came up with a horrendous figure of 17%. Dr. Fauci mentioned a somewhat lower figure, but it was still very high. Nonetheless, SARS eventually died out, and it's no longer considered a problem. The question really is concerning our experiences today. We have 43,000 cases in China, 1,018 deaths. We have something like 400 outside of China. There seems to be a disparity in how we perceive the relative frequency of mortality in these populations, and though it's clearly very, very early, the question is, do we see any differences?
Any differences
in what?
Between what and what?
Between the manifestation of the disease outside of China and in China.
Yeah, Nancy could answer that, but I think it's too early to really say anything about that. There are too few. If you look at the, close to 300 or more versus 40,000, the N is too small for the outside of China.
Yeah, just a comment about the drug companies and their reluctance to invest in vaccine development. They make a hell of a lot of money on other things like opioids, and without any conscience. And the other thing is they also benefit from the research that NIH does, where the NIH develops drugs, and then it gets passed on to the drug companies, and they make fortunes.
I think I saw a hand right there, and then we may have to end this. And somebody please tell me we're at almost 1:20. Okay. Okay, thank you.
Richard Coleman, retiree. I go to Taiwan frequently. A face mask is like a fashion accessory there. And I read in the Taipei Times that because the Chinese were looking for 100,000 a day and they only had 30,000, there was a real shortage of face masks, but they didn't want to ask Taiwan for political purposes. Number one, are we doing anything? I mean, this would be an act of great friendship. I don't know if our relationship would allow that for us to make masks. But number two, do they do anything? Are they worth even putting on?
How about?
Do you mean are they worth putting on now here?
No.
Are they ever? I mean, face masks are incredibly effective when they're used appropriately. So the best way, frankly, to use a face mask is to put it on the person who's sick. Yeah. Because source control is actually the best way to protect everybody else in the community. And we certainly have robust measures that we put in place in healthcare settings because we want to make sure that our healthcare workers are protected, since, of course, that workforce is essential for us to be able to respond. But right now in the United States, am I recommending that people go out and buy face masks? No, I think that would be the wrong way to proceed right now.
There was a gentleman way at the back who's been trying to ask a question, and then that'll be the last, I'm afraid.
Thank you. My name is John Osthouse. I'm a retired government employee. I was wondering, what is the status of an effort, if there is an effort, to submit an emergency supplemental to the Congress to get the funding that you're going to need to combat this problem?
I guess let me start by saying that, one of the things that was new for CDC at this outbreak was the availability of emergency response funds. And that really was a game changer for us. Frequently, when we have large crises like this, we have to wait for funds to be available, and it really impacts how quickly we can respond. It made a huge difference in this outbreak because, remember, we're talking about something that we didn't know existed before 6 weeks. We've had to move incredibly quickly, and the availability of those resources allowed it to be seamless and rapid, and we're grateful for Congress for making those funds available.
Yeah, I mean, in fact, if you remember back in the Ebola day, Tom Frieden, who was the CDC director at the time, and I were very public about wanting to have that kind of fund, and the fund was given $100+ million, which the CDC is very well using right now.
Right. If I could just add, I absolutely agree that the creation of funding last year by Congress of this emergency fund is a tool that the responders have that we didn't have 5 years ago, but that's not going to be enough. And I think that, again, particularly if we have more introduction of the disease in the United States, more state and local resources being pulled down, more resources in our healthcare system being pulled down, the administration is going to need an emergency supplemental. And by the way, that's a challenge on both ends of Pennsylvania Avenue. So on the one hand, I hope that someone at OMB is getting ready now to send this thing to the Hill and starting to really pulse the agencies for what they need. And I hope Congress is getting ready to act quickly. We were very fortunate in 2014, President Obama sent the emergency supplemental to the Hill. Congress passed it in 4 weeks. The next year, 2 years later in 2016, with the Zika response, it lingered up there for months before Congress acted on it. So yeah, I think let's just be fair here. I think there's a challenge for both ends of Pennsylvania Avenue. The administration needs to get this ready. Congress needs to be ready to act quickly when the administration sends it up.
So I think we're going to have to leave it there. Please join me in thanking these people for giving you so much time. Thank you.
Great job.